go ahead and get started. I think we've got most of us here. I'd like to welcome you guys to Fetal Boards. My name is Dr. Ashley Arnold. I'm one of the OBGYN residents. I'm third year. And I'm going to talk today about fetal growth restriction and small for gestational age, and comparing and contrasting these two terms that we use almost interchangeably. Today I'm going to talk to you about reviewing the history leading to fetal growth and growth restriction. I'm going to define small for gestational age and fetal growth restriction, review the etiologies of fetal growth restriction, and review ultrasound evaluation of abnormal growth. I'm also going to differentiate between a small fetus and the growth-restricted fetus. We'll review abnormal Doppler patterns, the timing of abnormal findings in relation to delivery, and the perinatal outcomes associated with growth restriction. So we'll first start with a little history. In the early 1900s, it was actually thought that all children with a birth weight of less than 2,500 grams were considered to be premature, even despite them having a normal length of gestation. And that's kind of our understanding of prematurity at that point. It was not until 1961 when the WHO decided that prematurity was not the correct word in the terminology for that. Instead, they separated into low birth weight, as defined as that less than 2,500 grams. And prematurity was related to gestational age. In the 1960s, a doctor by the name of Lula Lubchenco and her colleagues at the Colorado General Hospital in Denver published data which established our norms relating gestational age and weight in the newborn, and that created actually a characteristic growth curve that we're familiar with. She published a paper in the Journal of Pediatrics in 1963 on the data that they collected at the Colorado General Hospital in Denver. They looked at all the live births occurring at this hospital between 1948 and 1961. And this data included 5,635 live Caucasian births dated by their last menstrual period. 1,167 were excluded due to race. They also excluded any grossly pathological conditions, such as anencephaly, hydrops, maternal diabetes, and any fetus that was felt to be grossly incorrect by their dates, based on the physician who delivered them's impression. The continuum of gestational age and weight was plotted into these curves, which became the standard growth curve. She did note the significant differences between the weights in males and females, and the curves were divided by sexes, because there's approximately 100-gram difference between the sexes. So this is that growth curve that she kind of pioneered. And the growth curve is the one that we're kind of familiar with as far as in our pediatrics and our OB. It falls along an S-shaped curve showing non-linear growth pattern, and it was stratified by the percentiles, and that's kind of what we'll start talking about from here forward. So in describing her initial study, it was inherently flawed. She used a single hospital's data, a single state, at a single race, and at a high altitude. So we know that all of those factors are not our population. So as time has gone on, we've developed growth curves that have been developed to better reflect the US population as a whole in a more modern era. We know that babies now are a lot larger than they were in the 1960s. We also know that the race or ethnicity of a baby determines its growth curve, and they do have slightly different growth curves based on their ethnicities. So at a different gestational age, they may be at a different point than the Caucasian baby that was tested in the 1960s. These differences also have kind of been a point of contention in more recent discussions on what comparisons we should be using today. What growth curves should we be using? Should we be using local growth curves, or should we do individualized ones for that particular baby's risks of, with ethnicity and maternal height and maternal weight and all these other factors? So this graph illustrates the comparison of Lubchenco's curve, which is the dashed line, compared to a new set of data. It's a US data from 2010, which is the solid line, and that was published in 2010 that included 287 855 babies. These babies were born from a variety of 33 states between 1998 and 2006 in all races. So we can see that there's a little differences in these growth curves, and it does reflect more modern changes and in a more variety of patients. So regardless of this specific curve or population data that was used, all of these attempt to classify birth weight into 3 categories, and that's so that we can stratify risk. The small for gestational age is defined as the birth weight falling below the 10th percentile of all babies born at that gestational age. Here. Appropriate for gestational age reflects birth weights within the 10th to the 90th percentile. And the larger gestational age includes all babies born at a birth weight corresponding to greater than the 90th percentile. So let's start by focusing on small for gestational age. This term simply is the 10th, lower than the 10th percentile in birth weight of all babies born at that gestational age. This doesn't reflect a normal or abnormal growth pattern. It only reflects the size at delivery, and that's all you can take it for. This includes 70% would be constitutionally small but normal. They are not at increased risk of poor outcomes associated with growth restriction because they're just small. The intervention that we would offer potentially later on in pregnancy would be early delivery. That early delivery would not help this baby, and it would only lead to preterm birth without any benefit to the fetus. 30% of small for gestational age is abnormal. Approximately 10%. Some data shows different percentages, but about 10% have a chromosomal abnormality or an infection. We also know that unless it's caught early as far as infection, intervention in general does not change these outcomes. So a baby who's going to have a chromosomal abnormality delivered early doesn't do any better than if we leave it alone for a little while and try not to intervene. 20% have a utero-placental cause, and this is the key category that kind of what we really want to focus on. These are the ones where the interventions and early delivery, whenever it's appropriate, makes the most difference. So we'll talk about the definition of growth restriction. So the American College of Obstetrics and Gynecologists define fetal growth restriction as, in general, an estimated fetal weight of less than 10th percentile. But they do state in the very beginning of the paper, the practice bulletin, that there is a lack of consensus regarding the terminology, etiology, and diagnostic criteria for growth restriction. So that's our board. So it's very difficult. This is, like I said, that 20% that we're looking for is in that total of the small gestational age. So the key is to distinguish constitutionally small infants from growth-restricted infants so that we can see who will benefit most from intervention. Of course, if we set an arbitrary line at 10%, we're going to include fetuses that are normal but constitutionally small, and we're going to exclude fetuses that are greater than the 10th percentile but are growth-restricted. So we have to know that. So I'll just briefly talk a little bit about etiology. So you can kind of divide the causes by maternal, fetal, and placental factors. About 40% of the total birth weight variation from the fetus is due to genetic contributions from the mother and the fetus combined, and 60% from the fetal environment. We also know that both parents' genes affect childhood growth and final adult weight, but the mother's genes have a greater impact on the birth weight. We also know that fetal sex plays a role. The male fetus grows more quickly than the female fetus and weighs approximately 150 to 200 grams more at birth. Infection can play a role in growth restriction, as well as maternal toxins, such as smoking, alcohol, cocaine. We know that maternal smoking decreases the birth weight by 135 to 300 grams, And if it stopped before the 3rd trimester, its adverse effect is reduced. So even in the middle of pregnancy, counseling patients to stop smoking can help. We also know that fetal causes like congenital anomalies and multiples contribute to growth restriction. And the growth rate is a little different in multiples. The growth rate peaks at about 32 to 34 weeks in singletons, but at 28 to 32 weeks in multiples. Another source of etiology is the placenta. As birth weight increases, the placental weight increases. We see that trend. Fetal growth restriction without other anomalies is usually associated with a small placenta. It's possible that a fetus can outgrow its placenta and outgrow the capacity of the placenta to bring adequate nutrients. So that's something that we want to address early. So let's talk about screening. How do we screen for growth restriction, and who should we test? So we know that in our OB clinic every day we do fundal height, and this is a classic established physical finding that's easily measured, it doesn't cost us anything, and it doesn't hurt the patient to measure the fundal height. However, we know that the sensitivity of this test is about 27%. The positive predictive value is 18% in the general population, so it's not great. Another key we should look at is the risk factors. So if a mother has a risk factor for growth restriction, if she's had a previous baby with growth restriction. Women whose first pregnancy resulted in growth restriction have a 1 in 4 chance of delivering a second infant less than the 10th percentile. So those are the ones we need to definitely get scans on, at least a second scan after the anatomy scan. Also, patients with hypertensive disorders, they're going to be at increased risk for growth restriction. Smoking, like I talked about, multiples, and a documented infection. It doesn't mean that if a patient doesn't have any of these, it doesn't mean they can't get growth restricted, but we just know that these people are at a higher risk. We should also be screening people initially at the anatomy growth scan, but also, again, if they have any of these factors, they should be scanned again at 32 to 34 weeks. Okay, so we're relying on this ultrasound to tell us that this patient is, this mom and this baby is sick and we need to look at them closer. But ultrasound is inherently inaccurate. It's the best test we have for assessing fetal weight, but this study kind of showed that it's not always right. Shah Khan, I think is how he says his name, published a paper that was a review of sonographic estimate of fetal weight. And basically, he looked at a literature review on the accuracy of ultrasound at estimating fetal weight. They looked at 54 articles published on ultrasound compared to birth weight between 1975 and 2003. Most of these studies showed that the ultrasound was done within a 7-day window between the measurement and delivery. So it's pretty close. And overall, they found that only about 62% of predictions were within 10% of actual fetal weight. So we've got a significant portion that was outside that window. Chang et al. Looked at what parameter of the ultrasound might be best for catching or looking at small for gestational age infants. He reviewed 117 articles that used ultrasound to diagnose small for gestational age and fetal growth restriction. And these articles were published anywhere from 1977 to 1992. These articles compared rates in the high and low risk population, like I kind of addressed earlier. And they looked at a lot of factors, including the BPD less than the 10th percentile, abdominal circumference less than the 10th percentile, estimated fetal weight at less than 10th and less than 5th, grade 3 placenta, oligo, hydramnios, and an SD ratio of greater than 3. They found that in general, in the high-risk population, that the abdominal circumference by itself was actually the best single predictor of growth restriction at 84% detection rate. Estimated fetal weight came in at 69.8%. and oligohydramnios at 44, and the ST ratio at 52.6. The estimated fetal weight includes error, though. It takes each individual measurement and the error involved in each individual measurement and compounds it by creating an overall global assessment of the fetus. So the AC may be our best single measurement, but it's not used alone. It doesn't tell everything we need to know about the fetus. So abnormal growth is not just one ultrasound. So we get an ultrasound on a fetus, and it comes back low, comes back less than the 10th percentile. But that doesn't necessarily mean that this baby is growth restricted. It potentially is small for gestational age or constitutionally small. It needs to be measured over a period of time. The recommended measurement of fetal growth intervals in different literature you'll read anywhere from 2 to 4 weeks. You should see an increase in the AC of greater than 10 millimeters in 14 days by one study that was seen. Overall, there's not very many papers out there that say what change is acceptable and what change isn't. There's not necessarily a cutoff that 100 grams growth in this period of time is adequate and this particular growth is not. But there is, in general, we follow the parameters of average growth of 30 to 35 grams per day around 32 weeks. Of course, as I showed you before, growth is not linear, and so it depends on the gestational age as to how fast these babies should be growing. So this is like an idea of a small for gestational age infant. The blue is the normal, appropriately grown infant. And this outlines the 10th to the 90th percentile. This baby maybe started measuring at 28 weeks and was less than the 5th percentile. But as the trend of growth is shown, each measurement, for instance, at 28 to 30 weeks, improved in the same fashion that normal growth would be, and it's along the same curve. So this reflects a healthier infant that is growing and trending towards a good growth. Even if they're small, that doesn't necessarily mean that there's some pathology associated with this baby. It's a little more subtle at this small assessment, but in general, you can see that this baby's velocity is much slower. It's not going on the consistent trend that the previous baby did. This baby is growing, but it's growing in a slower fashion. And so that would be someone that may potentially need closer assessment, more closer watching and intervention possibly. So we know that growth is defined in 3 stages along the pregnancy. The first 16 weeks are mostly growth from hyperplasia, an increase in cell number. So the cells are dividing, and that is creating this fetus's growth. Right in the middle, 16 to 32 weeks, the growth is dominated by both. There is hyperplasia, but there's also hypertrophy. The cells are increasing in size. And then finally, the last, from 32 weeks to term, we know that there's predominantly cellular hypertrophy. So they're just growing in size now and not growing in number. This influences symmetric versus asymmetric growth restriction. In symmetric growth restriction, we see an early insult, which affects all the parameters that are measured. This fetus is affected early in those first 1 or 2 categories. Femur length, head circumference, abdominal circumference, estimated fetal weight should all be small. And it consists of about 20 to 30% of all growth restriction. And these etiologies can be something like early infection or drug exposure or chromosomal abnormalities that can contribute to symmetric growth restriction. Asymmetric growth restriction is characterized by an extrinsic insult that usually occurs later in pregnancy. This correlates with inadequate fetal nutrition and placental insufficiency. Usually what happens is the femur length and the head circumference are spared, but the AC is decreased because the poor hepatic growth and subcutaneous fat. The baby is not gaining that weight that we would normally expect to see. And these etiologies in general are more consistent with maternal hypertension and placental dysfunction. So this is kind of a little picture for us to see what I'm talking about. So a normal baby has a normal head size and a normal abdomen. A symmetrically growth-restricted baby is symmetrically small head and a small abdomen. But an asymmetrically grown baby would have a normal head size, but have a small abdomen. So we know that the fetus responds to its state of hypoxemia and acidemia. And we know that in general we use the term brain sparing. So what happens is in the fetus, there's a change in the blood flow to the various organs. See, the first insult that happens is the blood flows decrease to the kidneys, resulting in oligohydramnios that we can see. And it goes away from the body, resulting in growth restriction from the carcass. The blood flow is shunted to the vital organs, the heart, the brain, the adrenal gland, for survival. So that's kind of going to affect what we talk about next with our Dopplers and screening. We know that oligohydramnios is a fairly early sign of this because we know that the blood flow decrease to the kidneys is one of the first signs. So I'll kind of touch on Dopplers. The studies that are out there are looking at mainly umbilical artery Dopplers, middle cerebral artery Dopplers, and the venous circulation. That's the three categories that we look at when we're talking about Doppler studies. The umbilical artery Dopplers assess the placental vascular resistance. And we'll talk more about that, but they can help distinguish from a pathologically small versus a constitutionally small fetus. So this is a very useful tool that we have in our toolbox. The normal Doppler velocity in a small fetus is usually indicative of a constitutionally small fetus. So if the Dopplers in general are normal, it's more likely that this baby is normal and not pathologically small. It may also be normal in a chromosomally affected baby or have structural abnormalities. They can still be normal Dopplers. Although it's not very helpful in predicting fetal growth restriction, umbilical artery Dopplers have been the most useful thing to predict perinatal outcomes in the growth-restricted fetus. And we know that by using these Doppler flow studies, we can reduce the odds of perinatal death by 30 to 40%. So I'll kind of go over what we're talking about with Dopplers. So umbilical artery Dopplers simply trace the waveform from blood flow from the fetus back to the placenta for oxygenation. The umbilical placental resistance decreases as the gestational age increases. That's a normal pregnancy. Unfortunately, those that are complicated by fetal growth restriction have progressive changes that we can see in the waveform and trends over time. The SD ratio is one of the things that is useful to us that we look at, and I've shown you here that the systole is here, and this is over time here, and diastole. And so we simply take the systole and diastole and get a ratio, and that is correlated over time depending on gestational age. Like I said, as gestational age progresses, the resistance decreases in a normal fetus. And so we can compare these ratios that we're measuring to the norms that we can establish by trending these information. And those are available to us easily. So we know that resistance is measured most commonly by the increased ratio of the systolic to diastolic velocity. And if resistance falls with increasing gestational age at 30 weeks, the average should be around SD ratio around 3. At 35 weeks, 2.5, and by 40 weeks, 2 in a normal fetus. And we do have calculators and online things that we like to use to kind of make sure we're on track with these these norms. And I've put on one of them that Dr. Knoll and I like to use. to make sure we're on the right track, to give us the average on gestational age in weeks, to tell us what the SD ratio should be. So we see that there's progressive changes that happen. First is increasing resistance. The next change that happens is progression to absence. So what happens is you get absent and diastolic flow. And so like I said, so if this is systole, this is diastole, you have a period here where there's 0. It's absent. And the velocity is not moving. Once we see reversal, this is another progression to the next stage of severity in abnormal flow. And this is a reverse pattern. So you can see it comes actually inverted. And this is associated with a 5-fold increase in perinatal mortality. So this is a pretty ominous sign when we see this. So like I said, there's a progression. It typically goes from a normal SD to an increased resistance here to absence, and then cut off to reversal like I showed you in this picture. So what is the clinical significance of abnormal Dopplers? There is a paper published in 1994 by Kasdorp and al. That looked at perinatal outcomes associated with abnormal Doppler studies. They looked at pregnant patients that had hypertensive disorders and or IUGR from 9 centers in 7 European countries. They found that they did umbilical artery Dopplers every 2 weeks until delivery on all of their fetuses that were enrolled in this study. They found 459 patients. 253 of those had growth restriction. 178 had absence of flow. 67 had reversal. They saw that there was fetal demise noted in 24% of those with reversal, 14% of those with absence, and only 3% of those that had normal Dopplers. They also saw postpartum death in 51% of reversal, meaning they were born alive but died in the postpartum period. 27% with absence and only 1% of normal Dopplers. So they concluded that overall perinatal mortality is approaching 28% if absence or reversal is seen in the fetus. So we'll move on to middle cerebral artery Dopplers. These have been evaluated to assist in the management of growth restriction because it has a role in assessing the fetus's response to hypoxia by measuring the increased cerebral blood flow. So we're looking at evidence of brain sparing here. It has been shown that hypoxia leads to an increased pulsatility index of the middle cerebral artery, but it doesn't correlate well with improving outcomes. Unfortunately, it hasn't been shown to be very helpful at this point in assessing if we intervene, will this help the fetus? The third Doppler flow study that we can look at is venous circulation. This looks at the flow in the venous circulation and is measured at the ductus venosus and the umbilical vein. We know that abnormal waveforms show a progressive change, much like the umbilical artery Dopplers, and you can see an abnormal waveform in an absent or reversed A wave, and that is an ominous sign that is also correlated with impending acidemia and death within 7 days. So it's a pretty significant thing. We can measure this venous circulation Dopplers and see if we need to intervene soon. However, it's a late change. It does indicate poor outcome, but its absence is not necessarily reliably assuring. And ideally, you would want to know before 7 days out that this is something that you need to intervene on. So it's not been something that we've been able to use in that situation. So what is these forms? The ductus venosus has a characteristic triphasic waveform. It's composed of an S wave, which is consistent with ventricular systolic contraction, a D wave, which is represents early ventricular diastole, and an A wave, which is atrial contraction. And I'll show you a picture because I didn't know this stuff. So this is the normal ductus venosus waveform. You see the S wave, the D wave, and then the characteristic A wave, and this is in a normal patient. It becomes abnormal when there's this reduction in the A wave. It leads to absent or reversal of flow and can be measured by an abnormal pulsatility index, an S to A ratio, and an abnormal peak velocity. And then you can see reversal, similar to the umbilical artery Dopplers. So, management of growth restriction. So we know that we've talked about ultrasound. We talked about its inherent, could be off, could be inaccurate. But our best screening, fundal height being inaccurate, or someone with a risk factor, we want to send them to get an ultrasound. That's the best we've got. So the ultrasound then detects poor fetal growth, less than the 10th percentile. At that point, you still have to think this could be a constitutionally normal fetus, or it could be pathologically abnormal fetus. So you want to assess possible etiology, do an anatomy scan, look for chromosomal abnormalities, assess the AFI, look for oligohydramnios, look at the fetal genetics, screen for possible infectious causes. CMV, toxo, rubella, varicella have all been associated with growth restriction. Give them steroids. Go ahead and do that now. Then you would want to proceed to growth measurements every 2 to 4 weeks and initiate weekly BPP with Dopplers and twice weekly NSTs. And why would we do that? The Biophysical Profile has a scoring system for my pediatrician friends that incorporates dynamic variables, including tone, movement, and breathing, with the amniotic fluid volume and the non-stress test. It has been validated as a scoring system to improve outcomes with its use. And we know that there is a sequential deterioration of the BPP components, which is seen in worsening fetal status. So Bachat published a paper in 2001 showing the correlation between the BPP and the changes in the BPP over time, and correlated them with Doppler studies to see, as the fetal status worsens, what happens to the BPP. So all patients that were entered in this study started with abnormal Dopplers. So that's the basics. The first thing that happens is the Dopplers become abnormal. That doesn't affect. The BPP changes are later. Then at that point, the first changes a week prior to delivery are the deterioration of the Dopplers in this study. And this is, of course, an average. It's not every patient. Then they saw that fetal breathing was the next thing to go. The NST wasn't very helpful in the situation because they were almost always abnormal. So by the time the Dopplers were abnormal, the NST was usually abnormal also. So fetal breathing was the next to fall, and that occurred about 2 to 3 days prior to when the obstetricians decided to deliver these babies. 1 to 2 days prior to delivery, the AFI dropped, and on the day of delivery, you see a progressive loss of movement followed by loss of tone, and that's the progression that happens in the BPP, but that's pretty quick. So just talking about timing of delivery, so putting this all together, growth restriction is individualized. This baby needs to be looked at for all the factors that we've talked about. Potentially this baby is constitutionally small or pathologically small. You want to follow the growth pattern. The biggest factor in outcomes in babies that are less than 27 weeks is gestational age and birth weight. So even if this baby is having trouble growing less than 27 weeks, it's not likely to help by intervening. However, between 27 to 34 weeks, you want to intervene when necessary, but prolong the pregnancy and do very close monitoring on these babies, especially if you're having abnormal Dopplers, which have been shown to be potentially lead to delivery within 1 week. And at greater than 34 weeks, you really should seriously consider delivery if there was any reason to deliver, because at that point, it's more about intervention than gestational age. Perinatal outcomes that are associated with growth restriction. Overall, like I said, the outcomes are directly associated with the birth weight of the baby and the gestational age at delivery. We know that there's increased neonatal morbidity and mortality with each factor, low birth weight and small gestational age. But fetal growth restriction adds another factor on top of that. It's not just about gestational age. They also have an increased rate of respiratory distress, meconium aspiration, neck, hypoglycemia, hypocalcemia. They have polycythemia with capillary sludging due to hypoxia, and they have hyponatremia from impaired renal function, and hypothermia. So these babies are sicker than the small for gestational age babies. So like I said, the constitutionally small fetuses with normal growth curves who deliver near term are not at increased risk. So allowing these babies who are growing in a normal linear pattern that we would expect are not at increased risk for these extra morbidity and mortality associated with growth restriction. So long-term outcomes, what happens to these babies after they're born? In general, growth-restricted infants have a little bit of a period of catch-up. So they'll grow a little bit more than the normal appropriately grown infants. A man named Kitchen showed that 75% of growth-restricted infants that were less than 1,500 grams achieved a height and weight above the 10th percentile over an 8-year period of follow-up. So they were growing. They're probably going to be small, but that doesn't mean that they're going to be sick forever. But we do know that it's associated with increased risk of things long-term. So these babies could one day have problems with hypertension, heart disease, diabetes, COPD. Also, there has been an association with developmental delay that is seen especially in the severely growth-restricted infants. So hopefully that kind of gives you an overview and some things maybe you didn't know about growth restriction. So any questions? Thank y'all so much for your time.